we are going to have a very important discussion, how to go beyond quantity to quality of healthcare service delivered. And this is an important subject, and I'm glad that we are going to discuss it together. In my presentation, I want to give you some insight into how in Rwanda we build our health system based on equity, and that is now internationally recognized as a health system that is with quality. The question of quality is often disregarded when discussing health service delivery in the developing world. However, today, I will talk to you about what it means in my country. Rwanda built a quality health system despite being a low-income country. I will describe the challenges and success that we face and how our health sector has improved the health of our population through the lens of equity. We will explore together the key strategy we use to deliver quality health services and how trust plays an important role in maintaining a sustainable health system. So, just to give you some context, here in the next slide, you can see where Rwanda is located relative to where you are now in British Columbia. Rwanda is a small landlocked country based in East Africa, and with Burundi, Tanzania, Uganda, and DRC as its neighbor. We have about 12 million inhabitants, the majority of whom are under 20 years old. We have a high population density, 525 people per kilometer square in an area of 26,338 kilometers square. So we have a GDP per capita of $820 per capita. This was in 2019. And the country is largely agriculture-based. And for comparison, for the GDP, during that period, with the same calculation, the GDP of Canada was around 46,000 at the same time. 820, 46,000, just to give you a sense. Today, we are doing a lot with this little money, but 27 years ago, Rwanda dealt with one of the most horrific genocide of the last century, the 1994 genocide against the Tutsi. Within the 100 days between the 7th of April to the 4th of July 1994, 1 million Tutsis were killed, not with bullets, but with machetes. The infrastructure were destroyed throughout the country. Skilled health professionals were killed or fled out of the country because they were afraid to be killed or because they killed others and want to escape justice. The level of distrust at that time was high. We needed to rebuild the country, to rebuild everything, including the health sector, as well as the social fabric of our society. So during this period, Rwanda had extremely low level of health outcomes. We had the lowest life expectancy in the world, around 28 years, because of the dramatic lack of what we are calling at UJG the 5S. That means staff, health professionals, staff, equipment, space, infrastructure, I told you it was destroyed, and an efficient health system, and the support, because we know that poor people, if they are not supported, cannot come and benefit of the health service you provide to them. All this was coupled with poor quality of preventative treatment and care services. So this was 27 years ago. But you can see on the next slide here that the life expectancy in Rwanda had more than doubled. It is now around 69 years. And it's better than the countries in Africa that richer than us. And as you can see from the graph here, Rwanda outperforms sub-Saharan Africa despite our low GDP per capita. The next slide shows you why we have more than double our life expectancy. It's because at the same time, we decrease infant mortality by 75%, reduce maternal mortality by more than 80%, and increase childbirth at health facilities up to 91%. Keep in mind that we did all this with a GDP per capita that is very low and building a quality health system based on equity at its center. And I will discuss the importance of that later. In the last slide, 3 of the indicators were focused on women, children. And this, I did that by purpose because first, pregnant women and children under 5 are the most fragile citizens who are healthy citizens and should not die. Maternal death is the biggest cause of death among young, healthy adults, while children under 5 face an increased risk of illness due to an immune system that is still developing. Second, under 5 mortality is a very good proxy to measure the quality of a health system because the majority of under 5 deaths are preventable. So high under 5 mortality is indicative of a weak health system that cannot provide the quality needed for the citizen. Moreover, the decrease of under 5 mortality requires a combination of intervention that require at its center quality. These interventions include improved nutrition, what is not linked to the health sector, but agriculture sector, what is linked to also high immunization rates, that is also linked to the capacity to benefit of cold chain, that is related more to the energy system and the availability of electricity or another source of energy, and improve maternal health and education, among others. So you can see here you have the agriculture sector, you have the education sector, and you have the infrastructure sector that are coming to support the health sector to provide quality care. And Rwanda did not only reduce under 5 mortality across the nation, but did that across region and across wealth quintile. And this is where you see the impact of an equity agenda. And you can see from this gap that the gap between the line representing under 5 across region and wealth quintile decreased significantly, and the gap between them decreased over time as well. And this is important because many countries reduce, but not in rural, remote area. So we have seen that Rwanda was making progress in health outcome over time, the last two decades. However, we are now living in a global pandemic that threatens our health system, our political system, and our economic sector. Therefore, we need to identify to which extent this pandemic threatens our health system that when mothers and under 5 are concerned. As of August 2020, WHO reported that 90% of the countries saw a decline in health service delivered for under 5. And also, this is due to the disruption of health services, partially because of a limitation in the demand, because people were afraid that coming to the health facilities, they may be infected by COVID, but also because there is a diversion of resources, financial resource, human resource, to for the preparedness and the response to COVID-19. For example, in the supply side, service delivered, there was a supply chain disruption of drugs in many countries. There is a lack of human resource because human resource in charge of under 5 were pulled out to serve the COVID response. So next slide will show that despite this huge challenge, Rwanda built a health system that is resilient. This to such a type of health threat. By leveraging existing strategies that we use to reduce under 5 mortality, and also by implementing evidence-based intervention adapted to the local context. And this is very important. Don't come in Rwanda and do something that is very good for Canada. You need to do in Rwanda based on science what fits the local context. And because of that, we were able to maintain the delivery of services for under 5 children. Some of these strategies include, for example, transforming the car. When there was a lockdown, people had problem to go and seek services. So what the hospital did, they create a system of transport for people who were sick. And people, the community health workers in village can call for the services so people can join the hospital to get care. Same for transport of the personnel, because there were no more bus, no more motorbike to transport the people. There was also mass campaign to inform the community about, please continue to treat your children. Please continue to vaccinate. Go to the health facilities because it's safe. And to make health facilities safe, what we did, we create a total parallel system for COVID-19. If you are at risk or you believe you have been contaminated, you stay home, you ask a phone to call a number, a toll-free number, and they come in your house and they test you. If you are positive, they test all the family. And the system of contact tracing start all the people you have met recently. And they take you to bring you to a COVID center. So you don't go through the ordinary health facilities. This to keep the ordinary service running. And it's very important because fair, avoid people to go and get services and they die at home. So this mass campaign to explain what is the virus, how you can catch it, what to do to prevent it, what is the treatment and and care of it, and also how to continue to go and get ordinary service. It's not new. It's used every time we have an outbreak, but it's the same first time that we have such a, like all the countries, we face such a magnitude of a disturbance in the health sector, but we managed to continue to provide primary care to the people, and you'll see the outcome of that later. And this was possible because of the community health workers, of also the trust that we managed to create since 1994. So these strategies resulted in maintenance on its social health services and exemplify here by the coverage of vaccine and antigen that you can see, all of them remain constant. And I want to say that we may be poor, but we have the kids the best vaccinated on earth. 93%, sorry, for 11 antigen for the boys and for 12 antigen for the girls, because they have also HPV vaccine to prevent cervical cancer. We have maintained that. What was not possible to do at school, because HPV vaccine is done at school, because it has to be done before the first sexual intercourse, and also the children receive so many vaccine when they are small babies, and we don't need to give that before 12, according to the studies done in Rwanda. So this time it has been done near the houses. The strategy was to change where the service is given, but keep the service, and use advanced strategies, meaning nurses and doctors go to the population and the community health workers who are there in each village to help liaise the professionals and the communities. So we have, for this, an equity in decentralization, with each district having a district hospital, his sector having a health center, and each village 4 community health workers trained by the ministry, elected by the population, very trusted from the population, educate to teach the population about the danger, how to escape it, how to mitigate it, how to use the services, and trust, because they are pairs, they are elected, because first, they are trusted, second, they are educated. So the community, through them, contribute 100% to the primary level of care. A village is around 200 houses. So another thing is a early adoption of innovation strategies. We use it for under 5 mortality. That means every time there is a new vaccine, that's how the kids are well vaccinated. We use them. We use a drone to deliver drugs far. We use robots to care of people who have COVID. So all those innovations, we use software and data. When a child doesn't come for vaccination, the system signal it, the community health worker is informed, and it goes at home and see why. Does the parent doesn't want to vaccinate? Okay. But they want to vaccinate and they don't have a transport to go. So the system help them to get vaccinated. For the next slide, I want to say that if we have made those progress the past decade, since 1994, and if we have made those progress, it's not because, like many says, it's a miracle. Nobody can emulate that. They are special. That's not true. We are just focused on create system that leave no one out. And to do that, you create a system that focus on the vulnerable. Because when you have the vulnerable served, we are all served. I used to say that when the child of the poorest grandma in my country is served, the grandchild of that grandma, my child will be automatically served, because we know how to navigate system, what the vulnerable doesn't always know. So this is important. And for this, you need to create a system, okay, focus on equity, focus on the vulnerable, but also using science. And don't be afraid to tell the people, sorry, science changed, so we are going to give you the best, and explain. And never lie. When you lie once, they will never trust you for the rest of your time in services. So it is not ideology, it is not magic, it's not guessing, it's really focus. Vulnerable, equity, science. So there are 3 components that I want to share with you that has helped us to make progress in the health sector, is what I call the 5 H's, and told you that it was missing in 1994 because everything was destroyed. It is the staff, the space, the system, and the support. And this is needed, because if somebody is very sick and can have no support to go and get the care, at that time, you may set the best services However, they will not benefit about it. Second is the three ones. Rwanda has one national plan for health, one governing body that coordinates all the stakeholders, and one monitoring and evaluation that make all the stakeholders accountable. This ensures coordination of the health system and the delivery of service with synergy to avoid duplication and make the most of each dollar that is available. And it allows us to do more with less. And so the 3A are availability, accessibility, and acceptability. So it can be available very near, but I cannot afford it. So this means an equity in access to service, meaning everybody, we have more than 90% of Rwandans who have health insurance. Majority community health insurance, it's $5 per capita. Other people have an health insurance, health insurance based that can be private. We have also the military, the people in uniform who have their own health insurance. But that means that all those are voluntary. We have everybody, it's not legal to not have a health insurance, but the government have to pay for those who are recognized in their village as poor and cannot afford. And this is around 25% of the population. And the pair come together and say this family cannot afford. The father may have a job, etc., but if they pay the insurance for all, they will be bankrupt. So the government, by law, have to pay for this family. So accessibility, financial accessibility. But I also say that in each district, there is a hospital. In each sector, there is a health center with nurses. And in each village, we have community health workers. This is geographic accessibility based on equity. And acceptability, we do introduce new medicine, new drugs, new tool, or innovation, discussing with the people, explaining it, and make it acceptable to them, culturally acceptable. So the community interact with the health system and contribute to the health system. So these three components guide the weight we give to several factors that are important to the implementation of strategies to be successful and have good implementation outcome, taking in account the context. Next slide is about when we do not put emphasis on this component, inequities arise, creating a culture of mistrust. Why do people trust is because they know that we care. And the health system is part of creating inequities if we don't proactively make a health system that is serve everybody, especially the vulnerable. So we must note that disease is just the tip of the iceberg, and that there are many social determinants of health that contribute to make people sick or to prevent them to be treated if they are sick. And the top of the iceberg is often not recognized and denied. There's non-medical reason why the marginalized group are more susceptible to contamination for COVID, for example. They are more in condition to be infected. And when infected, they have less opportunities to get treatment. And because of that, and even when there is a vaccine, there has less opportunity to get access to that. So you need to create a health system that break all those possible barriers in advance and proactively. So if not, you can see that minorities die more with COVID because they have work that expose them more, they have less money to get access to treatment, and opportunity to get vaccinated. An opportunity to get vaccinated is not only to say this is the rule for vaccination. In the US, there is a research who just shown that because you line up using internet, a phone, and you have to come with your car, people without a car are disadvantaged. People without access to internet cannot line up. And those are the same who have job that doesn't allow them to work from home. Who have to go out with the risk to be infected. So those social determinants of health are many. And one by one, we need to debusque them and to deal with them according context. So a key component of the development of our health system is the prioritization of vulnerable through an equity framework. I have said that in the beginning. And the absolutely, we need financial accessibility, geographic accessibility, and cultural and acceptance and approval of what you do. And there is, in Rwanda, the population is interviewed by consultant every year that work for the parliament, asking what they think about the health sector. And it's not enough to provide good things. People need to understand they like it, and they understand for what you do that. If not, the parliament judge that you don't do a good job. Investing for the vulnerable is also important. And the return on investment is 4 times more than when you invest in the wealthy. And I talk about giving agency to the population, following the science and evidence-based intervention, innovation, holistic approach, don't go for treatment of prevention only, go for all, and cultivate solidarity and collaboration. Collaboration across sector, across village, yes, and also the solidarity, so that when you tell people, put a mask not to protect yourself, but to protect the elderly, they found that it's culturally appropriate and normal. So the next slide talk about how we have this pyramid of care. We have 15,000 villages. In each village, 4 community health workers elected. Above the village, 4 villages do, we have a health post with a nurse with at the level of secondary school. And 16 villages do around a health a sector with a health center with nurses and midwife. And after that, a district with doctors. This first time the population meet with a doctor, except when doctors do outreach to serve the population at the request of community health workers. And after that, you have the hospitals, referral and teaching hospitals and the top, only in big cities, and one by province. But you can see also that there is a system of mentorship, that the referral and teaching hospital supervise and mentor the district hospital, who supervise and mentor the nurse health centers, who supervise and mentor the community health workers. And this pyramid has also helped control COVID. None of them were used as COVID center. And all of them has a triage from the beginning, from day one, when we have our first patient, have a triage. All the people at risk of being COVID infected are tested and brought with a special transport, with people in ambulance with PPE, to a COVID center, and they were distributed across the country. This reassured the people that it was safe to go and continue to get care. So, in addition to provide care to all, regardless their sex, their capacity to pay, we also focus on giving the best. It's not because we are poor that we agree to give substandard. And we fight like crazy against international organization that found that it's normal to have double standards for lower income countries, even when it is WHO. Remember, if you have seen Bending the Hack, the problem with the multi-resistant TB, they give treatment. They knew that it treats nobody. They knew that the people will die. They knew that the MDR TB will spread across the country. But they keep quiet and continue to tell people this is the medicine you have to give. We refuse that. And for HIV, for example, we have universal access, and we have a rate of survival of our patient that is better than in Paris and New York, with a viral suppression that is better as well. So we also adopt and negotiate the best vaccine. That's how we have 93% of our girls age 12 vaccinate for HPV. So that means we have now one generation between 12 and 21 years. All our girls are at 99% prevented against cervical cancer. We also promote public-private partnership. I show you that a village is, 4 villages do make a cell, and there we have the village came together and built little health facilities, only 4 rooms, where there is a private nurse who is working there, providing care, reimbursed by the health insurance. They don't do hospitalization, but they follow you. And it's a private nurse in a building built by the communities and the support of the government to get access to supply, supervision, education. And also we invest in infrastructure. So our commitment to healthcare go beyond just prevention, and we focus on treatment. Here it's a rural cancer center, and we have there quality. It's just in front of hospital is our teaching hospital, quality care in rural area. And we show that we can give comprehensive care, not only diagnostic and advice. And for example, so during the lockdown, our students were not moving. I'm pleased to say that we never closed, even one day. And we managed to keep the campus free since March 2020. But our car were useless. So we put our car at the service of older people suffering with cancer and who need to go to get service, treatment, radiotherapy, or see the doctors and had the chemo. We know also that trust is the biggest factor for the health sector. If some countries that are very rich and has a lot of means didn't manage to control COVID, is because they have distrust in the population. Minorities doesn't trust the health system. They cannot pay for private, or they have not access to quality private practice. So they don't go to the health sector, because we remember the trial, the unethical trial done by doctors, government, civil servant doctors, vis-a-vis young Black people, pretending that they treat them for syphilis and just let them die, and see the natural history of syphilis, what was absolutely not needed. Those doctors has been not found guilty. The system were not found guilty. And so there is that in the subconscious of many, and they cannot trust to go and get services. On top of the fact that even when they want to go, it's more difficult for minorities. So by using participatory process and human-centered decision-making and focus on the vulnerable and inequity, we have managed to create trust. And there is a study last year by Wellcome Trust and Gallup Institute in the US, who have studied the trust in health sectors vis-a-vis the population vis-a-vis the health sector. I'm very proud to say that Rwanda was the country where the trust was the highest. So that's explain that with less than 200 respirators, we have managed to have less than 300 deaths over a year, 254. And just because the population was actively participating in containing the spread of the disease. So it's very different than 27 years ago. What I want to say that 27 years ago, we were in deep distrust, but we managed to create that trust over the time. So that means it's a hope, an optimistic story that I'm giving you there. We have built a health sector that the people trust better than they trust a 5-star health sector in other country, out of a country that was totally destroyed. The social fabric was destroyed. If we have managed to do that, the world can do that. So I think we can go directly to the last slide. Say also, you can pass that one. Task shifting is very important. It's a solution to not having enough health professionals, but it's also useful because nurses can do so much. They are educated, they know, and we should a little bit remove the ideas that the limitation of things we do and not using nurses at their full potential. Community health workers, some never finish the secondary school. They don't have to. They need to know how to read and to read. And when you see that you have a teenager who can inject himself his insulin alone, so you can train community health workers to do things. They are providing antibiotic, they're treating not complicated cases. They give family planning tools, even injection, the Propovera, and they are doing that so well. Next slide. This is the Human Resource for Health. It's a program that was done in Rwanda. 100 teachers from the US were coming every year during 7 years to help teachers to learn how to teach when teaching students. It has allowed us to increase the number of doctors. We double it, and we pass from 150 specialists in all the country to around 600 now. And because the system is ongoing, it's going to be exponential, even if we still have a long way to go. It's a government to government program, and the 23 institutions signed a contract with the Ministry of Health, but the program was good because designed by Rwandan for Rwandan and supported by the US. It was not designed by US University for Rwanda, no. Next. So the university that I'm leading now works to improve health, as Christina told you, for Rwanda regionally and behind, and globally. And the education we give, it's good clinical education, but also managerial skills for managing a hospital or health sector, and also advocacy capacity to make sure that they can go to the leaders and advocate for the people they serve. We teach humility and culture, or the value of understanding multiple culture, and so cultural humility. And it's very important. And our students, the first year of education, they are rotating under community health workers to understand how their work is so important and they are full part of the system. So this is what we create in 27 years, and thank you very much.
Thank you, Agnes. I have so many thoughts, but I just, a couple of things that really struck me. When you have the vulnerable served first, we're all served. And I think what typically happens here is we go with this concept of start where it's easy, the low hanging fruit, which are often you're saying don't do that. I think that's one of the biggest learnings that I've had today, that if we actually start with the most vulnerable, the rest will come easy. And I think that's a complete shift in the mindset that we've had. And just the idea about caring and people feeling cared for builds trust and creating that system that leaves nobody out. But I think most importantly, that a health system built on equity is a resilient system. And we have become so focused on the dimensions of quality that reflect individual experience, safety, access, effectiveness, and we haven't laid the foundation of equity first. And I think I think you've really challenged us in our thinking around that. I am curious, we do have some differences between our systems around the political influence between Canada and Rwanda. And I'm curious about anything about the Rwandan context that you feel contributed to your success. And then what advice would you have for us here in British Columbia around being able to start first with equity as we move forward?
It's never too late to bring equity as a big element of the equation, because equity will point out to the vulnerable, and you are going to design program for them. Because a program for when you design a lockdown, for example, there was a lockdown, and we have 60% of Rwandan that are working in informal sectors, meaning no savings. If they don't work today, they don't eat tomorrow. All the family. And we have almost 47 to 50% people who are poor. So before deciding the lockdown, meaning you have to be proactive, we knew that there was a mess in China in December. China rang the bell. And we had a plane coming from Rwanda going to China. We stopped it because we know we cannot manage such a pandemic. And also we start studying this disease. And we say they have done a lockdown. We study it. We call them and ask them, what happened? How did you do that? Through the ambassador and through colleagues there. And they say, you need the lockdown. So we plan for the lockdown. If we lock down, who are the vulnerable? They will not eat. So all the head of village has been informed. Place, we need a list of those who will not eat if we do a lockdown. There was a budget free for that. And also some money. But doing so, I have 200 houses that I elected the head of village here. Even if I'm living well, we have some poor here. The one who is responsible that everybody has something on the table once a day minimum is the head of the village. And people can complain if they don't have. And this man, because he accepts the role, is accountable. But we all come together. There is also something else that creates trust. Every last Saturday of the month, we all come together in the village to do community work. We are going to clean there. It's a land that the person is not there. Or we just discuss. And so we know each other. And we give also, we contribute, create collaboration and solidarity. You need to. And it's not the health sector who create that, it's the society. What the president did, you know what? He announced publicly, I gave my salary of April for the fund to feed the vulnerable on top of the contract. All the cabinet give, and we say, oh, we are all going to give. You understand? So create solidarity, and this is create by example. And so that means also there is a distribution of money, but there is a distribution of food, and there is a national list starting in village. And this, we were ready for that. So in March, I remember the 14th March, Friday, First case, everybody know what to do. And the government said, you have the weekend to go and pick your thing. Monday, at this time, nobody will move. And if you need to move because you are sick, you have a community health worker, you can go in your village, you can even send your kid, call for me an ambulance, and the ambulance come. So you create a system that allow, and it's, you know, it doesn't cost money. It costs organization and trust.
Dr. Binagwaho, I think that is a remarkable half an hour that we had with you, and I think all of us are really quite left with a lot to think about and left with a lot to take forward. And I think the word that I have written down is trust, because I don't think I've honestly seen trust numbers like that in surveys or information otherwise. So for this morning and for coming to us for such a long distance, and
I tell you, trust is the biggest social determinant of health ever.
which is a great way to finish for us. Thank you very much. And we really appreciate your time and your expertise. So thank you for spending time with us. Appreciate it. Thank you.
I appreciate it. Thank you very much, and have a good day.
Thank you.
Thank you.
Take care.